welcome everyone. Let's talk about tachyarrhythmia and what are the treatments like cardioversion and drugs that are used for tachyarrhythmia. Of course, the conducting system starts from the SA node, then goes to the atria, it causes contraction. Then through the AV node, there will be some delay before it goes to the bundle of His, then left and right bundle branches. Through the Purkinje fibers, it gives electricity to the ventricle, it causes contraction, then after that relaxation. The QRS complex is important to know that the QRS should be less than 3 small square. So this is a small square. It should be less than 3 small square, which is less than 120 millisecond. The PR interval, which starts from the start of the P to the R, PR interval here, should be between 3 to 5 small square, which equals to 120 to 200 millisecond. And the QT interval usually is between 350 to 450 millisecond. Today we are talking about tachyarrhythmia. To read an ECG rhythm strip, if you use these steps, it would be much easier for you. First, is there electrical activity? Second, third, fourth question are about QRS. What is the QRS rate? What is the ventricular rate? So between the 2R intervals, if the rhythm is regular, between 2R intervals, for example, here R, you have to know how much is the how many large squares are there. 1, 2, 3 in this case. So you have to divide 300 by the number of large squares between the R interval. It means 3 large square. So this patient have a rate of about 100. The rhythm is regular or irregular. So these are regular rhythm. The spaces between R interval are regular. But in this case, it is irregular. So wide, then narrow, then wide, then intermediate, then narrow. Then another thing, the QRS width is normal or broad. As we said, the normal QRS should be less than 3 small square. Then the fifth question, is there atrial activity? Atria is represented by P wave. This is P wave, this is T wave. So is there P wave or not? And the last question, what is the relation between P and what's the relation between atrial activity, which is P, and the ventricular activity, which is QRS? So in this case, for example, there is good relation between P and QRS. There is good relation between P and QRS. So if you read the ECG in these steps, you can know the types of ECG change. So what are the most common tachyarrhythmias? The first one, if you have a rapid, this is rapid heart rate, regular, narrow QRS, and the P waves are there, and it is sinus. Sinus means there is good relation between P and R and interval. This is called sinus tachycardia. Sinus tachycardia is usually have an underlying cause. Example, the patient is having pain, stress, pregnancy, or the patient is having hypovolemia. So you have to treat the cause. Thyrotoxicosis. Second most common is atrial fibrillation. Atrial fibrillation is the second most common, in which is there electrical activity? Yes. What are the QRS rate? Usually QRS rate is rapid in these cases. Is the rhythm regular or irregular? It is irregular. Fourth question, is it narrow or wide? It is narrow. What about atrial activity? There is no atrial activity. There is no P wave. So this is there is no P wave, and it is irregular. It is atrial fibrillation. Another important case is SVT. In SVT, it is rapid heart rate, it is regular rhythm, but it is narrow QRS and there is no P wave. This is just a T wave. There is no P wave. In this case, it is supraventricular tachycardia. So this is the third most common. Another type is when the patient is having rapid heart rate, it is regular, QRSs are wide, but there is no P wave. It is most probably 80% is due to ventricular tachycardia. The ventricles have tachycardia, or it might be a bundle branch block and having SVT. This is another possibility, but usually you have to treat it as VT if you are not sure. Another one is less common. When the patient is having rapid heart rate, it is irregular, the QRSs are wide, it is no P wave. So it looks like an AF. The only problem is that the QRS is wide. That's why it's called AF with bundle branch block. Usually in bundle branch blocks, the QRS will be wide. So these were the most common ECG changes which you see it in the emergency department: sinus tachyarrhythmia, SVT, atrial fibrillation, VT, and also AF with bundle branch block. There is another type, call it atrial flutter. It looks like this, but there will be flutter waves. There is another ECG which is common, is called it's not very common, but it could happen every now and then, call it torsade du poids, in which there will be wide QRS, then narrow QRS, then wide QRS, then so as if the QRS is twisting around an axis. How you manage a tachycardia? If you look, this seems to be very complex, but everything starts with ABCD. So it's important to know whether your patient is stable or unstable. After doing ABCD, gaining IV access, sending for investigation, correcting electrolyte abnormality, you have to know whether the patient having adverse features or not. If there is adverse feature, you have to give DC. If there is no adverse feature, you have to classify your type of arrhythmia, then give drugs or give treatment accordingly. So let's look at the initially. As we said, you have to do ABCD. If there is an adverse feature like shock, it means the patient having low blood pressure plus cold periphery and anxious patient, and they have increased capillary refill time more than 2 seconds. This is shock. Or the patient is having syncope, transient loss of consciousness, repeated time of syncope, and the patient is having full recovery after that. Myocardial ischemia with the tachyarrhythmia, the patient have chest pain that increases with exertion, relieves with rest. There is ischemic ECG change, there is troponin release, so you say this is myocardial ischemia. Heart failure, the patient have shortness of breath, hypoxia, crackles in the chest, leg edema, or hepatomegaly. So if the patient have one or more than one of these adverse features, they are regarded as unstable. What is your treatment? You have to give first, second, and third DC. How you give DC? It should be synchronized DC under sedation. Sedation means that you have to give some morphine, pethidine, or you call the anesthesia doctor. They give them anesthesia drugs, GA drug. Example, they may give also ketamine. So this should be synchronized. What we mean by synchronize, if there is a QRS and the T wave, QRS and the T wave, QRS and the T wave, the ECG machine, the DC machine, when you do synchronization, it looks at the R interval. It only gives DC when it recognizes the QRS. It gives DC directly on the QRS, because if wrongly the DC gives asynchronously on the T wave, it may lead to asystole. So what we mean by synchronization means you synchronize the electrical activity with the the electrical DC with the QRS, with the R wave. You give 3 DC. If the patient not improved, in the fourth step you have to give amiodarone. You give amiodarone in a dose of 300 milligram, usually 2 ampoule, in a rapid way, 10 to 20 minutes. Then, if the patient still not improve, you have to give fourth DC, but this is the fifth step. If the patient still not improve, you have to give maintenance amiodarone, which is 900 milligram over 24 hours. I have to notify you that amiodarone better to be infused through the glucose water. So in the sixth step, you may give amiodarone, but also it's better to call cardiology to help you for further management. So what if the patient refuses DC? What if the family of the patient refuses DC? Usually this does not need too much consent because the patient may die, but if they didn't agree or you don't have ability to give GA to the patient, you are in a faraway area, then you may start amiodarone as soon as possible. Is there a substitute for amiodarone? What if the amiodarone is not available? Instead, you can give lidocaine. Lidocaine ampoule, you have to give 1 milligram per each kg. When you say lidocaine or xylocaine, 1%, if lidocaine is 1%, it means per each ml you have 10 milligram. 10 milligram per each 1 ml of, if it's 1%. If it is 2%, it means for each ml it contains 20 milligram. So this is the dose of lidocaine, which is used instead of amiodarone sometimes. There is also other drugs like flecainide, but flecainide, the problem of it is that it should be only given to the patients without structural heart disease. So, if the patient have no adverse feature, it means if the patient is stable, have no shock, syncope, heart failure, MI, then you have to look for the QR, do a 12-lead ECG, look for the QRS. If the QRS is broad, it means more than 120 millisecond or more than 3 square, then you have to look whether it's regular or irregular. If it is regular, it is ventricular tachycardia most probably. So if the patient have VT and the VT is stable, no adverse feature, you give amiodarone 300 milligram over 20 to 60 minutes. So you give 2 ampoule over 20 to 60 minutes. Then 900 milligram, which is 6 ampoule over 24 hours. If you are previously sure that this patient was having an SVT with bundle branch block, then you can use adenosine and treat like regular narrow complex tachycardia. If the QRS is irregular, if it is irregular but wide QRS, then you have to ask for cardiology help because it might be due to AF with bundle branch block. You treat like an AF, like a narrow complex 1, or it might be pre-excited AF, WPW syndrome plus bundle branch block. You consider amiodarone, or it might be polymorphic VT, called torsade de Poix. In this case, you have to give magnesium 2 gram over 10 minutes. So these were for stable, wide complex tachycardia. Let's take some examples. One of the examples is that, is there electrical activity? Yes. The QRS wave is narrow or wide? It's wide. Is it regular? Yes, it's regular. Is there P wave? There is no P wave. So wide QRS, regular without P wave, this is most probably ventricular tachycardia, or it might be SVT plus bundle branch block. So 80% is might be due to VT, the possibility. But there are some discriminating features which can be, for example, capture beat or fusion beat. So if you have capture beat, fusion beat, you can say this is a VT for sure, or increases the probability. If the patient having ischemic heart disease, the most probably is due to bundle branch block. This patient again is having wide QRS. It is wide. There is irregular rhythm, because there is different spaces between the RR interval, and there is no P wave. So no P wave, irregular means atrial fibrillation. But when you say wide, it means it's associated with bundle branch block. There is increase in the QRS with the narrowing. Increase the narrowing. This is called torsade de poids. Torsade de poids is usually due to magnesium deficiency. So you have to give 2 grams of magnesium over 10 minutes. So this was about stable broad complex. But now we are talking about stable case, have no adverse feature, but the QRS is narrow. So if it is narrow, you have to look for the QRS. If it is regular, there is P wave. It's most probably, if there is regular and P wave is there, it is sinus tachycardia. Usually sinus tachycardia, you have to treat the underlying cause. But if it is regular and there is no P wave, it is usually due to an SVT. So for SVT cases, you have to do vagal maneuver, then give adenosine, then other pathways of treatment. I will talk about it shortly. If the patient not improved with the treatment, it might be due to re-entry paroxysmal SVT. So you have to call, sometime rhythm is not controlled. It might be due to atrial fibrillation, a flutter. So you may give a beta blocker. If it is irregular and narrow complex, no P wave, it is most probably atrial fibrillation. So in atrial fibrillation, you have to treat by rate control, rhythm control, and prevention of thromboembolism. This is an example of a case who is having a QRS which is narrow. It is regular rhythm, and there is a P wave. The PR interval is constant and regular. So this patient is having sinus tachycardia. Sinus tachycardia, you have to search for the underlying cause and treat the underlying cause. Rarely you need controlling the rate in sinus bradycardia. Only if the patient is having thyrotoxicosis or anxiety, you may give beta blocker or calcium channel blocker. This patient is having regular narrow complex tachycardia with no P wave. This is T. There is no P wave. So this is an SVT. What are the steps of management of SVT? The first step is by doing vagal stimulation. How you stimulate vagus nerve? One of the most successful ways is to do modified Valsalva maneuver. I will show you a video about this. Carotid massage, carotid artery massage, because it contains the vagus nerve. And gag reflex. The gag reflex, because oropharynx, the vagus nerve passes there. If you stimulate, it causes bradycardia, or it causes resolving of the SVT. Others like immersion of face into cold water is also there. If the patient not improved, second step is, this was the first, the second step is by starting giving adenosine. The adenosine ampoule is 6 milligram. It should be given as rapid as possible. Usually we are diluting it with about a 20 milliliter of normal saline or distilled water, and then give it very rapidly within seconds to the patient. It is better to have, for example, this is the hand of the patient. It's better not to have a cannula like that, having a cannula in the antecubital area. I means near the heart. It's better to be left-sided cannula. And then when you give the fluid very rapidly, when you give the adenosine, elevate the hand as well. Before giving adenosine, you have to warn the patient that you may have a chest pain and flushing of the face transiently. This chest pain is good because it means the drug was effective. Adenosine, the most important contraindication is asthma. You have to know all things about adenosine. So you give 6 milligram. If not responded after 1 or 2 minutes, you can give 12 milligram. If not responded, you can give 18 milligram. So 1 ampoule, 2 ampoule, 3 ampoule. If the patient not responded, then you go to the third stage. In the third stage, you either give a beta blocker or a calcium channel blocker. The calcium channel blocker that you give is either verapamil or diltiazem, because these drugs can lead to controlling the heart rate. The verapamil, the dose is 5 milligram. It should be given IV over a 2-minute period. Usually verapamil is available. The trade name is called Izoptine. So this is the trade name. If calcium channel blocker is contraindicated or not available, you can give a beta blocker. Example of beta blocker is metoprolol. The metoprolol ampoule is usually 5 milligram. The tab is 50 milligram. So you give it slowly over a period of 5 minutes IV. Please do not combine beta blocker plus calcium channel blocker, which is rate limiting. If you give both of them at the same time, it may lead to severe bradycardia. This is a modified Valsalva. If you have a case of AF, so this patient is having irregular narrow complexes without P wave. So these are not P waves. These are just fibrillating waves. Irregular, no P wave, and narrow QRS. This is atrial fibrillation. Whether atrial fibrillation or atrial flutter have the same treatment. What are the treatments? So first of all, we have to classify the patients of AF by paroxysmal, persistent, permanent, or new onset. What we mean by paroxysmal? Paroxysmal when the patient's AF lasting less than 7 days, terminating either spontaneously or with treatment. We mean by persistent when it is lasting more than 7 days, which is terminating usually with treatment. The permanent one is the permanent when long-standing AF is there and a decision is made not to treat the rhythm. So no treatment, no rhythm control here. You just control the rhythm, just control the rate, sorry, in a permanent one. So in history, you may know whether it is permanent AF or other types of AF. Sometimes it is, most of the time, it's new onset coming to the hospital. A new onset or paroxysmal or persistent. So if there is a space for treatment, if it is less than 48 hours, you can do a rhythm control. Rhythm control. If more than 48 hours passed from the time, from the starting of the AF, or the history is not very well known, the timing, then rate control. How you do a rhythm control? Either pharmacological, I mean by drugs. The most commonly used drugs for AF are flecainide and amiodarone. The dose of amiodarone is 300 milligram over a period of 30 minutes, then maintenance of 900 milligram of 24 hours. So when you give this, usually the rate and the rhythm will be controlled. If more than 48 hours, then okay, coming back to the less than 48 hours. If less than 48 hours, we say drugs, or sometime the cardiologist decides to do it by electrical cardioversion, electrical rhythm control. So the electrical, they use DC, but before giving DC to such patients, they may do some esophageal echocardiography, or they may give anticoagulant for 14 days, then 2 weeks, then they do DC shock. For the rate control, you can use either beta blocker or calcium channel blocker or digoxin. Beta blocker and calcium channel blocker should not be combined, but beta blocker can be combined with digoxin. Calcium channel blocker can be combined with digoxin if the patient is not responding. If a patient is having AF plus heart failure, the best choice to start with is digoxin. So either rate control more than 48 hours or rhythm control if it's less than 48 hours. For preventing thromboembolism, because for the heart, when there is atrial fibrillation, there is fibrillation of these atria, no enough contraction. There might be clot formation. That's why this clot might dislodge and go to the cerebral artery, leading to stroke, or going to the renal artery, causing renal failure. So Church-Vasc score is used to identify patients at risk of clot formation. C, congestive heart failure. H, hypertension. A, age more than 75 receives 2 score. D, diabetes. Previous stroke receives 2. Peripheral vascular disease. Age between 65 to 75, 1 score. Sex category, female. So if the patient having more or equal to 1 score, usually it indicates to start anticoagulant. The anticoagulant that we give in our emergency department is usually Clexane or enoxaparin. For the prophylaxis, usually we give 4,000 international unit 1 by 1 subcutaneously. So this is for most of the cases in the emergency department. If discharged and decision to be made to give anticoagulant, we may give apixaban, rivaroxaban, dabigatran. So these are new anticoagulants. But sometimes the patient cannot tolerate these drugs because they have a valvular heart disease. At that time, we may go to the warfarin. Okay, so this is all about AF in the emergency department. Usually you have to concentrate on whether you do rhythm control or rate control, and which drugs you use is important as well. Again, if a patient is unstable, having signs and symptoms of shock or syncope or heart failure or MI, at that time you have to directly go to the rhythm control with the electricity. So you just give a rapid DC under sedation with synchronized cardioversion. I have to tell you that adenosine is used to narrow complex tachycardia, especially SVT. It's contraindicated in asthma. The doses are 6 milligram, then 12 milligram. Then the new guideline tells you the next time you give 18 milligram. So this is the third dose. It blocks conduction through the AV node. The patient feels that they have a chest pain, and also they will be having transient flushing of the face. This is VT. For VT we use amiodarone if they are stable. Amiodarone is usually used for broad complex and narrow complex tachycardia as well, sometime in AF. The dose is 300 milligram over 20 to 60 minutes if the patient is stable, then 900 milligram over 24 hours. Once the patient have normal rhythm, you have to stop the amiodarone. It's preferably given through the central venous catheter because extravasation may lead to skin necrosis or gray skin syndrome. Actions, it prolongs QT interval, it lengthens duration of action potential. If it is given rapidly, it might cause hypotension, so be careful. If hypotension happens, you have to slower the rate of giving amiodarone. So this is again a case of VT. In the summary, now you should be able to recognize different types of tachycardia by their regularity and by their width of their QRS. Understand the principles of treatment, whether you give DC, whether you give rate control, or whether you rhythm control. Knows the indication of electricity or chemical cardioversion, and knows how to perform a synchronized cardioversion. And thank you so much. Thanks for Housing Organization for reorganizing the slides, and thanks for Howler Medical University and Kurdistan Society of Emergency Medicine.